I'm very happy to have Peter Mazzone here with us today. Peter directs the lung cancer program and the lung cancer screening program for the Cleveland Clinic, and in his spare time works on the development of lung cancer biomarkers, has been sort of very thoughtful and a leader in our various societies on how to apply biomarkers for the management of lung nodules. So I'm happy for him to give us a brief overview of this process and the potential use of biomarkers in lung cancer management. Peter.
I just want to thank Neil for inviting me to speak to you today about molecular biomarkers for lung nodule management. What I hope to do in the next 10 minutes or so is to highlight why we need this field to develop. What is the need for molecular biomarkers for lung nodule management? And then talk to you mainly about some principles. What are some biomarker principles? And how do we know when a biomarker that's developed for this purpose is actually ready to be used in the clinic? What level of evidence is required for us to be comfortable? Well, Nicole highlighted the need. This is a table from her publication that suggests, regardless of the probability of malignancy in a nodule, a lot of these nodules end up having invasive biopsies. And since this study's been published, I've tried to think a lot about why that may be. Is it that we just don't follow guidelines, or is it a little bit deeper than that? And so I've thought about my own practice quite a bit as I see people with nodules, and we've developed our own care pathway based on the guidelines and asked, how easy is it for me to follow this care pathway? And what are the challenges where biomarkers may help? And I've found that it's mainly in this low to moderate probability group, here labeled as 5 to 65% probability, but depending on your patient characteristics, that may shift a little bit. And I found that sometimes I've done everything I can. I use PET scanning and I don't get a negative result, but I don't get a glowingly positive result. I've either tried a navigation bronchoscopy or needle biopsy, or I recognize that that nodule just isn't accessible to one of those non-surgical procedures. And so I'm left stuck in that low to moderate probability range, and the only two options are to follow and watch or to proceed with surgical resection. So it may look like I'm not following my own care pathway because I've exhausted all of the options I have. And it's once I've exhausted those options where I really think there's a role for lung nodule molecular biomarkers. So how will I know that a molecular biomarker is ready for clinical use? There are many kinds of molecular biomarkers being developed. Lung nodule evaluation is what we're talking about today, and they all go down a similar pathway. There's discovery level studies where a molecule or pattern of molecules is found to be different in the condition of interest. There's analytical validation studies where the assay that's being developed is found to be repeatable, precise, very accurate. There's clinical validation studies where that assay and a fixed threshold for what you're going to call positive or negative is applied in the population you intend to use the marker in, and you learn how accurate is that marker actually in that population. And then there's clinical utility studies that says, knowing how accurate that is, how do clinicians then use that marker to change their decisions? And are those decision changes to the benefit of our patients? What I'll talk about for the remaining of my time is the clinical validation and clinical utility phases. Once you've done clinical validation, how do you know that your marker might be clinically useful? For a company, when should they invest in that next level of study, and when should we, as users of these products, decide that this has reached prime time? So once you're at the clinical validation phase, you have to think really, what is the potential clinical utility of this biomarker? And for lung nodules, a very general phrase might be that you hope that this marker will help you expedite therapy for an early lung cancer and or minimize aggressive interventions for benign lung nodules. With that in mind, if you're going to make a clinical decision change, that potential clinical utility must say that this has the chance of improving on what I do today, either the accuracy of my own clinical judgment, of the lung nodule risk calculators that you might use in practice, or in the other tools we have, such as PET imaging. And that improvement has to be either through biomarker use alone or by combining it with what you're already doing. There are two ways that you might interpret a biomarker. One might be a change in probability, you're shifting probabilities, and the other might be an absolute yes or no, be aggressive or watch. If the biomarker is going to be reported to change your probability, then you have to determine, is that improved accuracy enough to move my pretest probability past a clinical decision threshold? If it's more accurate, but it still just leaves me in that middle bucket where I don't have any other tool to offer, then it's probably not going to be very clinically useful. The other way, if you just say yes or no, you have to determine, will applying that biomarker as this dichotomous result, positive or negative, favor pursuit of a clinical utility study? Because there will be a trade-off there between your true results and your false results. So let's look at each of those interpretations. The first would be a change in probability. You're at the clinical validation phase, you know what your accuracy is, you trust that result, and now you want to shift to one of those other buckets, either to the bucket where you're just going to watch the patient or the bucket where you're going to be very, very aggressive. The numbers listed here are pretest probabilities. With these pretest probabilities, a biomarker of this accuracy will shift the final probability, the post-test probability, past that clinical decision threshold. So if your biomarker is 90% sensitive and specific, a positive result will put you past that decision threshold as long as the pretest probability was over 17%. If it was 10% to start with, then you're still in that middle range. You're really not going to change a decision much. And a negative result will move you from anything below 50% to less than 10%, shifting you to a category where you're going to make a different clinical decision. Now, 90-90 may be unachievable. That's an extremely well-functioning biomarker. What if you had 80 and 40? Well, 80% sensitivity, 40% specificity will only move you past 65% if it's a positive result, if you're already over 58%. And will only move you below 10% if you already start below 18%. So when you're deciding after clinical validation, is this worthwhile to perform a big clinical utility study or to use this in clinical practice, you have to understand how much it's going to shift you from one category to the next. If you look at it the other way, you're going to interpret this result as either positive, I'm going to be aggressive, or negative, I'm not going to be. And here we'll take an example, the same test accuracies. Now we have 1,000 individuals who have lung nodules that have a probability of malignancy in that middle range, 40%. If I applied a test to 1,000 individuals, and that test is 90% sensitive and 90% specific, you will help around 900 of them. 360 through expediting treatment, 540 through avoiding aggressive treatment. But you will harm 100, either 60 through unneeded treatment and 40 through a delay in your diagnosis. Again, if you went down to 80 and 40, you see how those numbers shift. Now, you have to determine what is the right balance there. How much help is worth a little bit of harm if you're interpreting a result as a dichotomous yes or no. There is another method used to help us to determine when clinical utility testing may be worthwhile. A formula that was developed and published by Margaret Pepe that helps you to use a benefit to harm ratio that's accepted in clinical practice to estimate when a biomarker of a certain accuracy may be clinically useful. And here are a couple examples in one direction and the other. So for an intermediate risk lung nodule, the benefit of a true positive is expediting treatment of a localized cancer. And the harm of a false positive is treatment for a benign nodule that otherwise wouldn't have been treated. Now, if you value that outcome at 5-to-1, and I just put that number there, means you're willing to expedite treatment on 5 people to do a surgery on 1 to resect a nodule or be more aggressive with 1. And I don't know the right answer, but if that's what you're willing to do, then the formula would state that sensitivity over 1 minus specificity has to be around 7.5, and an example of that would be a marker that's 75% sensitive and 90% specific. If you look at it the other way around, as a rule-out test, benefit of a true negative would be to avoid further aggressive testing in favor of surveillance, while the harm of a false negative may be delaying the diagnosis of a localized lung cancer. Now, if you value that balance at, say, 3-to-1, I'm willing to avoid an aggressive evaluation in 3 people, recognizing I might delay diagnosis in 1 person with an early stage lung cancer. Then the calculation would give sensitivity over 1 minus specificity of 2, and an example of 40% specificity and 80% sensitivity might encourage you to consider this a clinically useful biomarker or encourage industry to pursue clinical utility studies. Well, if you think that the marker is good enough to go on for clinical utility evaluation, what level of evidence should you be looking for to determine that this marker is now ready for clinical use? And there is some guidance in the literature. Study designs of any one of these 3 are felt to be acceptable. Retrospectively, the molecular biomarker has been determined to be clinically useful either retrospectively from archive samples obtained prospectively prior to the diagnosis of a lung nodule if multiple such studies are performed and show consistent results, or in a prospective study where the biomarker is not used to guide lung nodule management, but the primary objective of the trial is to assess the utility of the test. And then finally, the home run would be by incorporating the biomarker into the decision about how to evaluate the lung nodule in a prospective fashion. With study designs of that nature, what study outcomes might you look for? And these are just my own thoughts. The molecular biomarker should have been shown in one of those studies to lead to either both fewer false positives and false negatives than current standard practice. Then it's reasonable to suggest that the clinical use of those would be better than standard of care, or earlier diagnosis of malignant nodules without substantially increasing the number of procedures for benign disease, or fewer procedures for benign disease without substantially delaying the diagnosis of malignant nodules. Of course, the catch there is what is substantially, and I think that's what we have to decide as clinical practitioners. So thank you for your time and for the invitation, Anil. I hope that this provides a little bit of perspective on the challenges of molecular biomarkers development in this field.